Hello and welcome to another episode of the MSK Active podcast. I am Nick, podiatrist and director here at MSK Active, and we are joined by Dave, our rehabilitation specialist here at MSK Active. So, this month's topic, knee arthritis. So, what is it? So, if we look at osteoarthritis of the knee, it is effectively narrowing of the joint space and some of that cartilage starting to wear away. We used to think it's this term wear and tear. So as we get older, things just wear out, and that's not exactly true. We think of it now more as wear and repair. So every time you load a joint, there's the processes that happen, and what should then happen afterwards is that there should be a repair process that follows that to replace the cartilage and everything else that's being used during that activity. And arthritis is effectively that repair process isn't happening anymore. So what causes it? Let's address the elephant in the room. We still believe, people still believe that running causes knee arthritis. I just want to go out there and just sort of dispel that myth straight away, is that running does not cause knee arthritis. Actually, there is evidence to suggest that running and high impact activity may actually be protective of someone actually getting knee arthritis. So it's actually a complete flip around of what we used to think to actually what actually happens. And to give a brief overview of why, we always used to think that impact forces, so when you jump, the forces going through the body is what aggravates joints. Well, we're starting to learn that the impact forces isn't the main issue here. It's more looking at something called muscle vibrations. So it's how much do your muscles vibrate when you jump and land. The more they vibrate, the more load that will end up in the joint. And actually the best way to try and maybe reduce some of this muscle vibration is lean muscle mass. So in simple English, just being stronger. So other things that may cause it is that we know if you've had a history of trauma. So if you've had an injury to the ligament in the knee, or a meniscal problem, or any trauma in the past, we know that you are at an increased risk of getting osteoarthritis. We know that as we do get older, we know the prevalence of arthritis does increase as well. And we also know there are some family traits there as well. We also know that obesity can be linked to someone getting osteoarthritis as well. So there's some of the common things that are what actually may cause osteoarthritis. But then it's now thinking about, okay, so Dave, how can we treat it?
I think one of the first things to do to treat it is just the thought process people have around it. If I do more, I'll wear out quicker. And it's that fear. I know somebody who had arthritis, ended up in a wheelchair.
Yeah.
So it's putting it in the right place and where it should be in the thought process. So you think, well, I've got some arthritis. That makes me normal. Treating it, well, we used to use medication that had various, and we still do, has various effects. But moving, and we don't need difficult science for this. If someone moves and they feel better, it's probably a good thing to do.
So people always say, how do I treat it? Is treatment the right word?
Well, that's saying that we can cure it. So, and words are very important. Is it an injury? Is it a disease? Is it a condition, a syndrome? What would we label it, and why would we label it?
You hit why. You know me, I'm on a massive sort of thing at the moment of where I just want to demedicalize it. I don't want to have the label of arthritis, because we know we'll get to a point where actually more people have it than won't have it once we reach a certain age. So why do we need to label it? And I'm not a fan of treatments for knee arthritis or treatments for arthritis in general. I'm a fan of more of, management tips, as it were, because you say we can't turn back the clock. as it currently stands in 2023, we cannot replace human cartilage on a repeatable and reliable scale. So it's not as a case of, right, your cartilage starts to wear out, you go have an injection, we'll just pop some more in. We can't do that currently yet. Now, I don't know, 2024, we may be able to. I've got no idea. But this is what, at the moment, I think it's a case of you can't treat. It's all about management of it. So you talk about exercises. Why is that important?
If you think about the joint and the stability of the limb, particularly knees, it's almost just like a piece of 4x2 balanced on another piece. Mm-hmm. But what gives it the stability and control? Yes, it's the joint shape, but it's the muscles. And when we move, so if we've got stronger muscles, they're more efficient. We're taking a lot of load off the joint.
Yeah.
So it's been able to move in a way, and it's difficult, but I've got pain. If I move more, I'll have more pain. Okay, that's a good place to start. But if someone does move more, I've got less pain. And that's a difficult thing to explain or difficult to get across or even just to get your head around.
It is, but when we see patients in clinic with arthritis, they'll say in the morning it's stiff.
Yep.
Or after a period of sitting down, it's stiff. But actually, when I get moving and the more I move, it actually starts to feel a little bit
interesting,
better.
Isn't it? It feels stiff in the morning. Say knees, backs, ankles, wherever you've got it. Or I'll go for a walk. Once I started, and this is, if you do too much, too quickly, load management might hurt and you might have overdone it. But if you do a little bit and stay within your capability, and it's very difficult to know where that is, so that's a journey to work out and to find. Stay within your capability. I can go for a walk, and actually, I feel better now.
And I want to pick up another point, is that the journey, this is the thing. Your journey would be different to my journey, which would be different to Charlie's or India's journey. Yep. We're all different. So the journey we're going to go on is going to be different. So the management strategy in place, it may have the same overarching theme, but actually the practicalities of how that is carried out is going to be unique
Very
to
different. Because I know from my last MRI of my knees, I've got lots of arthritis. I don't have any pain, and it doesn't stop me doing anything. So I don't worry, I've got arthritis, I need to stop. No pain. Maybe I'm just lucky at the moment, but I know I've got it.
Well, if you come on to that, I've had patients, this is the issue with imaging. It's fabulous, but it can also sometimes throw a bit of a spanner in the works, can't it? Because we cannot correlate imaging to pain and symptoms.
Yeah, they can take a picture of what's there, but they can't take a picture of pain.
Yeah.
Yeah.
So we know, I've had patients where they've got what is known as grade 4 osteoarthritis. So that means there's no cartilage left and it's purely bone on bone of the knee, but they've come to see me about a foot-related problem because it's stopping them running marathons, as it were. And that's interesting because he's got grade 4 osteoarthritis, still running marathons, and the knee causes them no issue whatsoever.
Yep.
I've seen patients where they've got minor arthritis on x-ray, but actually causes them a large amount of symptoms. So you can't say the more arthritis someone's got on the scan, the worse the pain's going to be, unfortunately.
No. And we know that's very straightforward, isn't it? There's a lot there, and you can put it into categories. And Lorimer Moseley, in his book, he puts a lot of really interesting pain stories. It shows how complex pain is. He tells the story of a guy who goes he's Australian, to the emergency room with a nail through his foot.
Yeah.
And he sat there and there's a bit of a long wait. And all of a sudden there's a big commotion in the waiting room. What's wrong? Have you hurt your foot? No, I stood up and banged my knee on the table. And he's got a nail in his foot. But the bang on the knee was the thing that caused him the problem.
Pain that's just a whole different podcast, isn't it, on pain, because it's a fascinating topic.
But it's often the thing that people worry about with arthritis. Can you cure it? Where's it going to lead me? And they often will go catastrophise.
Yeah.
And to keep themselves safe, to make it better, I'll stop doing things. when actually the opposite is what's needed, and we need to gradually and progressively build things up.
And that's interesting because you're right in that when people come to see us in clinic, they have the initial perception that it's pain is the primary motivator of why they want to do something.
Yeah.
However, when we sit down and go through the initial consultation process and get to know the person, they actually realise pain isn't the primary motivator. It's normally a case of, I want to be able to go do something with the grandkids. I want to be able to go out walking with my husband or wife at
What
the
quality
weekends.
of life, and I want to be able to do more.
Yes.
Yeah.
And you turn and say, well, actually, if it hurts a little when I do that, well, I'm not bothered as long as I can do it.
Yeah.
But society tells people that pain should be your primary focus. But actually, when you sit down and speak to people, pain isn't the primary driver of all of this. It is more about being active and being able to do things. It's more of a primary motivator.
And people will often worry about doing too much, but people don't often worry about over resting.
Yeah.
And because they're resting, the knock-on effect to other body parts, the legs, hips, feet, the muscles, which are absolutely fine, then become a bit deconditioned. And then that is the reason that they can't do as much. But it's always blamed on, oh, it's this or it's that.
Yeah. So going back to the exercises side of things, so we're talking about with the knee that we need to improve the strength around the hips or quadriceps and possibly the ankle region. But what about just general exercise in general? Is that going to be helpful?
Anything. The worst thing you can do is nothing.
Exactly.
Move, test it out. What can you do? Well, I'm all right doing this, but on these days I do a bit too much and then it hurts. And there's very rarely a pattern, or it just comes and goes. Sometimes it's nice to keep a diary and break it down, and a pattern might emerge. But one of the things that we do find is, well, I did a bit more and it didn't hurt any more than the days that I didn't do a great deal.
Yeah.
So rather than, well, it was because I went for a long walk. Was it really? Or was it the same amount of pain as you had on the day that you didn't do a great deal? And just to start noting that can be really helpful. And then it's doing exercises within your limits up to the point, and it's very difficult to stop while you're still feeling good.
Yeah.
Especially if someone's, right, I'm going to get a little bit stronger, I'm going to work some muscles, I'm going to this, right, well, I feel good, how do I know my limits?
Yeah, and that's all really useful stuff, because when it comes to the exercise, yes, you need to build the strength around the rest of the joint, but you use a lovely term of, well, if we can make your knee pain, if we can help you make your knee pain better, do you feel the rest of you is ready to go and do everything that you want?
Exactly, yeah.
To do. And I think it's we can be guilty sometimes of trying to overcomplicate exercise, and it doesn't. It just needs to be nice and simple. It needs to be bespoke to the individual. You need to overcome all of the potential barriers that are stopping someone from doing that exercise and build something personalised and progressive for that
That's
individual.
often the barriers is part of the discussion. What's stopping somebody do it? Because most people know that it's good to move and good to be fitter and stronger. That's a well-known thing. But then I can't because I'm worried about making my knee worse. I'm worried about, oh, I haven't got time. I don't enjoy it. What is it that's stopping someone doing the things that generally most people know that they don't want to be weaker and stiffer? Now, I do want that, but...
Yeah.
And then there's the discussion. And
so when we talk about treatment, so that exercise is all about improving your capacity, your body's ability to do more. Then other treatments could be then about offloading the knee, taking some of the load away from the knee. And that can be with braces. That can be with some people find using a rocker shoe helpful. So things like your brand of Hokers or your Saucony Endorphin trainers, shoes along that, like that can be beneficial. And then there's also some people find that actually using insoles or putting things in your shoes can be helpful, because if you wedge the foot in certain ways, you can reduce the load in one aspect of the knee and then increase it on slightly other aspects of the knee as well. So it's all about building that tailored plan. But if you think of it as two approaches, at one end you're trying to improve your strength and overall capacity, so your body to do more, and then the other end is you're trying to reduce the load. And by doing that, you can then give yourself the biggest treatment window possible. And then there are other things that you can have all different types of injections to help with
Yep.
pain relief.
And the pain relief then gives you a good window to build the muscles, to do the capacity, to improve your quality of life, to do more of the things that you want to do, or do what you're doing for longer.
Yes.
And it's about longer life and quality of life. It's not, what was it saying? Not years. Oh, I can't remember.
No, you can't remember.
It'll come to
So
me.
that then leads nicely onto a question we always get asked is, will I have to have a knee replacement? Because obviously we spoke about conservative treatment measures, non-invasive apart from an injection. But actually surgery can be a treatment tool in treating knee arthritis. But it's always a fear of, I got knee arthritis, I'm going to end up in a wheelchair, or I'm going to have my knee replaced. Is that always the case?
I think it can be, and it can be a very good outcome. But what do you need to do? They can put a new piece in there, but what's the bit that keeps you moving and takes you for the walk is the muscles. So if you get your muscles strong before you have a knee replacement, you have that. The first thing you've got to do after any operation is get moving and get the muscles back. So the worst thing you can do is get fitter and stronger.
Yeah.
And that's a win-win situation.
Exactly. You always, in my head, just think of it as this sort of treatment continuum, or management continuum, as it were. So you start off with doing the stuff that we know can hopefully work, with the strengthening, with insoles, with footwear, with braces,
Because it may be, actually, that's really helped. I might need a knee replacement, but I've pushed it back 5 years because I can do everything I want to do now. And, actually, it hasn't been enough. I'm still going to have that knee replacement. But when you've had it, you still need to work those muscles.
Exactly. It's the way I phrase it to patients is a case of, it's trying to put you back in control of your knee arthritis rather than it controlling you.
Yeah.
And yes, you may end up having a knee replacement. We can't predict who will and who won't. But as Dave has already said, that, well, if you go into that surgery, whether you're having a arthroscopy, whether you're having a full knee or half knee replacement or an osteotomy, it's the fitter and stronger you can go into surgery, we know the better the recovery period is going to be anyway. So the worst that can happen, as Dave said, is that you just get a little bit stronger.
And I've remembered, it's not years of in your life, it's life in your years.
Oh,
so the more years you have, quality of life in those years.
Yeah. And when we then talk about the surgery, we know that for some things like arthroscopies and all the latest research comes out that actually, if you look at the long-term studies, a lot of people aren't finding any benefits of just having arthroscopies done compared to just the general exercises and just doing nothing. And the case of, you take your knee, for example, you got arthritis in the knee. So what? I'm still going to go cycling. I'm still going to do all my strength work. It's there. As long as I do my strength work and I keep active, we all live in harmony. So if it's not broke, don't fix it.
Yeah.
Scenario.
It's not worrying about something, well, I've got this. I know that those strength things are helping and keeping me going. Rather than they're not wearing me out quicker.
No, exactly. Well, I think that's a nice place to end this episode on. So thank you, Dave, for coming on. Hopefully you enjoyed that episode. Any comments, please do get in contact. Please do subscribe to the podcast, and we shall see you on the next episode. See you later. Bye.